Hi. If you're new here, you could go to the trailer, and if you were lost, you could go to the table of contents. Otherwise, obviously, this video is about lamotrigine, trade name Lamictal. Lamotrigine is anticycling, but it's not strongly anti-manic enough to prevent a manic episode. So at that end of the mood spectrum, it has to be combined with something, can't be relied upon by itself. Otherwise, though, it's really ideal for the bipolar 2, the yellow-orange region of the mood spectrum. And by extrapolation, I think it's very appropriate for the middle of the mood spectrum, but there's almost no research in this kind of unnamed zone. Nevertheless, according to population research, those blue, green, and yellow-orange regions, that kind of bipolar disorder is 2 or 3 times more common than the red or manic depressive version. So that makes lamotrigine a very important medication. So I'm going to compare now the pros and cons of 3 main alternatives particularly for that middle portion, where the majority of the people with bipolar are. And we'll just look at the pros and cons of each. And in the process, I'm going to then detail a non-medication alternative. What do you do if you're on an antidepressant? How do I manage the dosing? How I actually start the medication? How I have handled the safe rash. There's a dangerous one, but there's a safe one. And how to handle tapering off of lamotrigine. Those are all the details that follow this comparison of the 3 main guideline proposed medications. Here we go. The 3 are lamotrigine, lithium, lurasidone, trade name as Latuda, and quetiapine, trade name Seroquel. And I'll just go quickly through these boxes. The pros of lamotrigine: no long-term risks if it's properly managed, and no side effects for most people if it's properly managed, and over 25 years of experience with it. There's a 1 in 2,000 risk-ish, depends on which reference you look at. Some say it's more like 1 in 1,000, but the better data, I think, suggests it could be as low as 1 in 3,000. In any case, it's a rare allergy that can be horrible, severe, or even life-threatening, hospitalizes people. 1 in 2,000. It's rare. I've never seen it. Prescribed prescribed lamotrigine hundreds of times. Fortunately, I was lucky, never saw it. At most, I would see 1 in my practicing lifetime, any given psychiatrist. It's that rare. 1 in 10, though, there's a benign rash, and that scares everyone because we just got finished talking about the dangerous one, and I'll talk more about how to handle that, but it is benign in the sense that it's not life-threatening. It often causes people to think they can't take lamotrigine, which I think is incorrect. And another disadvantage of lamotrigine is that there's a titration. It takes a while to get going, really not much longer than an average antidepressant takes to give an antidepressant a fair trial, but lamotrigine has a reputation because of this titration for being slow. I think that's somewhat unfair. By contrast, lithium almost certainly has an anti-suicide effect. That's still debated in some quarters. It might have an anti-dementia effect, and I have a video on that elsewhere on this channel. Generally, I think of lithium in the low doses of lithium as an add-on. And at those low doses, there's also a video about that on this channel. It has very few risks and side effects. It does have a thyroid effect even at those low doses, and it has kind of a negative reputation, lithium. And about 1 person in 10 gets so dull on it they really can't take it. That's in my experience. Lurasidone has an antidepressant effect. That's true, but I think sometimes maybe a little too much so. And we have far less experience with it. It just became generic. The dosing's kind of tricky because it changes depending on whether you've had some food recently, how much your body absorbs, and finding the right dose is a process, I think. And it's not weight neutral. It's supposed to be much better in terms of not causing weight gain than others, but not entirely weight neutral, as is lamotrigine. So these have been dubbed the three L's. I think of them as mood stabilizers with antidepressant effects. You could call them MSAEs, like SSRIs for antidepressants. We ought to have another name for MSAEs, mood stabilizers with antidepressant effects. The three L's are lamotrigine, lithium, and lurasidone. Now, I think you actually could make it four L's because light has an antidepressant effect, and combined with darkness and rhythm, circadian rhythm, has a mood stabilizing effect. So light, conveniently appearing through my window, just as I mentioned this, um, is another L for the mood stabilizers with antidepressant effects. These are all in contrast to this other one that shows up on that list. In fact, at the top of guidelines, which is quetiapine. So the quetiapine, um, it has an antidepressant effect, and we have years of experience with it, and it really helps people sleep, kind of whammo. Um, but it causes weight gain in nearly everybody, and weight gain is associated with a medical condition called metabolic syndrome, abdominal weight gain, blood pressure increases, cholesterol increases, and an increase in cardiovascular risk. And recent data suggesting that metabolic syndrome can make bipolar depressions become treatment resistant. So metabolic syndrome is pretty much a disaster. And now we fortunately have these alternatives, the four L's, as alternatives for bipolar depression. So I'm a little bit outside the guidelines, quite a ways outside, in not putting quetiapine at the top of the list, which most recent guidelines do. And I have a whole video on why, more detail on why I don't follow those guidelines if you want to see. So the rest of this video is more details about lamotrigine. I'm going to slow down a little bit on the presumption that you're interested and want to hear about these. And in my head, the first thing to think about is that there's a non-medication alternative, even to lamotrigine, which I like over all the others. But even better is the non-medication alternative, which is namely that light and darkness and rhythm. And I have a whole separate video. Let's see, I think I linked it here. To put a card up for it, about using sleep regularity as a mood stabilizer. And when you shift your sleep rhythm earlier to come closer to the sun, that has an antidepressant effect. So it's a MSAE, a mood stabilizer with antidepressant effects. Let's see now. The beauty of that one is that it basically applies all the way across the mood spectrum, including in bipolar 1, the manic depressive version. And yes, here's my video about that, and I'll put a card up on that to link straight to it. Now, suppose on lamotrigine, you or someone whom you're contemplating lamotrigine for is already on an antidepressant. That makes things more complicated. In my view, it would be nice to remove the antidepressant first so we don't contaminate the trial of lamotrigine. But suffice to say that lamotrigine tried when an antidepressant is already in place. Lamotrigine didn't get a fair trial and should be tried again later when the antidepressant has been slowly tapered out and has been gone long enough for things to clearly be at a new baseline. That's obviously a very long process, and pretty much the most common in my clinical experience for the kinds of patients whom I saw. And I have another video about tapering an antidepressant that I think might be useful in that context. Now, dosing. The adage is get to 400, but most people start running into side effects beyond 200, and most people don't get side effects at 200 and less. And some people get great benefit at as little as 100. So my target initially is 200, but I get there a little more slowly than the typical titrations. I have people cut the pill in half to start, so they start at 12 and a half instead of 25, and spend a week at 75 on the way to 100, and a week at 150 on the way to 200. So my titration takes 2 weeks longer than the standard one that you'd read about. I'm just going a little more slowly, mostly to avoid that benign rash, because if that happens, it freaks everybody out. And going more slowly does lower that risk of the benign rash, as well as the really rare, dangerous rash. So go slowly, and for sure, never go any faster than the usual guidelines. So I think I just described my way of starting, 12 and a half for a week, go to 50 for a week, 37 and a half for a week, 50 for a week, then a week at 75, a week at 100, a week at 150, and then 200, all the way along going, is that far enough? Have we got enough improvement or not? And then I would just pause there, otherwise continuing to 200. And then most people having no side effects, going that little more slowly helps avoid headache and nausea, which are two common things that are associated with going up too fast. If those happen, I just back up and go up more slowly by smaller steps. Now, the safe rash, the benign rash, the standard guidance is if that happens, stop it. And it is not easy to differentiate it from a dangerous rash, but it is definitely possible to do so. So a skilled practitioner, a medically trained practitioner, can help evaluate the benign rash, red, itchy, heats up in the shower, and no other features of systemic illness. And if your practitioner was to decide that you have the benign one, a neurologist colleague once taught me that, yeah, okay, turn the dose back down a step, wait until that goes away, and then go up more slowly again thereafter, as a safe alternative to just giving up entirely. And there's a reference in the literature, if your practitioner needs it, from Dr. Chris Aiken, on handling even more dangerous looking rashes and re-challenging with lamotrigine safely. So I think that can be done. And I've written a couple of pages about that on some of my websites as well. And then finally, tapering off lamotrigine. It should be tapered just like we should taper most anything psychiatric. In general, I've not had the experience of people having withdrawal symptoms with coming off lamotrigine, but that's described many places on the internet. I think it's far, far less common than antidepressant withdrawal, but it can happen, and the solution is to taper off lamotrigine, don't just stop it. So, in summary, lamotrigine is one of the 4 Ls, the 4 mood stabilizers with antidepressant effects. As you can gather, it's pretty much my favorite, except for the light and darkness approach. And that's because it has the lowest risks of the pharmaceutical mood stabilizers with antidepressant effects. I'm going to link here sleep control as a mood stabilizer, and I'll send you as well to that why I don't exactly match the treatment guidelines if you want more detail about that. Thanks for watching.